So next we call upon Dr. Sheetal Brar. Her topic is feasibility and safety of a safe. Now we'll be taking in line photo. Yes, Dr. Sheetal, you can go ahead. Yeah, you are Dr. Sheetal, right?
Yes.
Yeah, she's.
Good morning, respected chairpersons and dear friends. Today I'll be talking about a new device, which is a safety device, a rescue temporary device, which can be used to improve safety in PCR occurring during phacoemulsification and prevent the risk of nucleus drop. Myself and my co-author, Dr. Sri Ganesh, have no relevant financial disclosures in this presentation. So, unarguably, out of all the complications of phaco, posterior capsule rupture or PCR is one of the most devastating complication because it is also associated with other complications such as vitreous loss, nucleus or fragment drop, which invariably need a retinal intervention, which also leads to collateral damage in the form of CME, uveitis, secondary glaucoma, also challenges with IOL placement. And all this eventually will lead to delayed visual rehabilitation for the patient and increased overall cost of the treatment. So if PCR happens during ECC or SICS, we know it's not a big problem. It's easy to manage. There's already a big wound and you can prolapse the nucleus out. But when PCR occurs during phacoemulsification and fragments are there in the anterior chamber and you want to manage it through a small wound, this is a big challenge. And this also entails a high risk of nucleus drop or fragment drop. So presenting to you a new device, we call it as safety net device, we have developed at Netradhama Eye Hospital. This is a new temporary rescue device made of biocompatible, implantable, foldable hydrophilic acrylic material. It is circular in shape and has an overall diameter of 7.5 millimeters. So on the left side, you see the version 1 of the device, which is like a net-like structure with square-shaped holes. So the holes were square-shaped with a size of 0.8 into 0.8 millimeters. On the right side is the version 2, which we are currently using. This is a little different. You can see that there are 4 bigger holes in the periphery, orthogonal 90 degrees to each other, and each of these holes is 1 millimeters in size, and the rest of the device is filled with smaller holes of 0.45 millimeters, and the overall thickness of the device is 0.2 millimeters. So let's look at the practical use of this device. So this is a case where I had a PCR during phacoemulsification. The cataract grade is also almost grade 3 to 4 here, and so here we see the practical utility of this device. So first, before implanting, if there is any vitreous, you must clear the vitreous and then bring all the pieces. First you need to bring the pieces above the iris plane and then clear the vitreous, and then you can load this device in a 2.8, a regular 2.8 millimeter injector, and you can implant it over the iris and under the fragments. So and then you can adjust it using a Sinskey hook, and now you need to fix this device. You cannot use it without fixing, so you need iris hooks to fixate the device. And so you can make 3 paracenteses and fix the device using the 3 iris hooks. Make sure that you fix it properly, and you just most of the times need 3 points of fixation instead of 4, because on the 4th side the fragments themselves will stabilize the chamber. So now once the device is fixed, you can easily go ahead and emulsify the fragments with the phacoemulsification itself. So here you do not actually have to increase the size of the wound, and you can manage the whole PCR without the risk of having a nucleus or fragment drop with ease. And here you can see this is the last fragment being removed. And use of this device is also quite easy and simple. So once its job is done, you can just remove the hooks, and using any forceps you can take it out. And then now you can easily clear the vitreous properly. You can do a proper cortical cleanup, and then you can assess the situation properly, and then decide the type of lens which you want to use. So this is another case I'll quickly show. This is the version 2 being used. So here you can see almost 50% of the nucleus is there in the chamber, and so we inject our safety device under the fragment and over the iris. And we have those 4 holes, and in the 4 holes we take the iris hooks inside and fix the device at 3 points again. And once the device is fixed, now our job is easy. So we can just go ahead and emulsify the fragment. So indications would be any situation in phaco with potential risk of nucleus or fragment drop, gross zonular dialysis where bag is not salvageable, or a case of nucleus drop being handled by a retina colleague where there is no access to fragmentome. Prerequisites will be definitely you need some amount of ambidexterity and familiarity with the use of iris hooks, must be secure at 3 points, and if there is vitreous, you need to clear the vitreous before inserting the device. Contraindications or caution: if there is a lot of, say, more than 3/4 of the nucleus is present and there is no space available, then it may be difficult to insert it under the fragment or the nucleus. If the nuclear fragment is very dense, hard and brown, endothelial count is less, and if the pupil is very widely dilated, sometimes you have those traumatic cataracts where the pupil is very widely dilated, so there also it may not be a good idea to use this device. And if there is a sphincter damage or associated iridodialysis again, and if there is poor visibility. So we have used this device in about 24 eyes in our institute. 5 eyes had PCR in the private.
6 minutes are over.
So I'll just
our discussion time is done.
Conclude that safety net device may be a useful device to prevent nucleus drop and its complications during phaco. Its timely and judicious use may prevent devastating complications of nucleus drop.
Yeah.
And retinal surgery.
I request everyone to please stick to your time, because then our discussion time goes away and you also land up with some minus points. First thing is, it doesn't allow the fragments to go back or drop,
yes,
but it will keep allowing the vitreous to come out.
No, ma'am. The first thing is that we have to first recognize the PCR. The moment we recognize the PCR, we normally what happens is
will it allow the vitreous to come out? Logically it will.
Through the net.
Through the net, the vitreous is bound to come, no?
It can come.
It is bound to come.
But the thing is that we need to first do a...
No, what we need, that's fine, but it can come, right? See, the wrong message should not go. It doesn't allow the piece to drop is perfectly fine. It's very logical.
Yes.
But it definitely, the vitreous is exposed to all your management and suction. And the less the management done with vitreous means less you touch is always better. And do you think, suppose you have a VR option, that you have a drop or you are going to have a drop and a VR surgeon can manage it, and on the other hand you have this net, you would go for a net?
Yes, ma'am.
You would go for
Definitely.
a net, even if the vitreous keeps coming.
Ma'am, it's vitreous
two points which went against this. The whole purpose of that net is only to not allow a drop. But it is not giving
a major retina surgery.
It is not giving any respect to vitreous. We are increasing the wounds. We are making 3 more extra wounds. That is one thing which normally, if this is going to come out, why make more and more wounds? The best thing is to close it with proper anterior vitrectomy, not anything in the AC. AC should be without vitreous, and hand over the eye to a VR is the best option. In general, that is the gold standard, we believe, right?
Yeah.
Okay. No, that's okay. It's just, I'm not contradicting you. It's
my
just
question is that, how it is advantageous over IOL scaffolding?
Yes. So IOL scaffold technique, in that technique you use a 3-piece lens to tamponade the piece.
Not necessary. If you have got an intact bag.
That's in the intact bag, sir.
Yeah.
Here the indication
Just
is very
PCTR,
specific,
PCB,
where you already have an intraoperative PCR. So when you have PCR, you anyways have a very high risk of nucleus fragments dropping. So this is a device which can be used to prevent the drop. Also through a small incision, maintaining the small incision. Now you may ask me that it is easy to extend the corneal wound or make a scleral tunnel and prolapse it out, rather than using this device. But again, in that when we are prolapsing the nucleus, there's already because this is a very special situation. The PCR has already occurred and there is already vitreous. So when we are prolapsing the nucleus through a bigger corneal wound, then we are also creating
No.
lots of
We-
corneal.
I'll just put one
wound-related
point. You are
complications.
1 minute,
is
Dr.
not
Cheetah.
there.
You are contradicting your own slide. You said in ECC and SICS, it is much easier to
Easier
manage.
to remove the nucleus.
It is going to bring that much vitreous
Easier to
also.
remove the nucleus,
Anyway, that's fine. So the
but
point is
preventing
taken.
the
That's done. Okay.
preventing
Sir,
the
you
drop.
have some.
Okay, that's all.
That was the idea. That is the
I would support doctor that if there is an anterior capsule is round and perfect, so what we normally do is we put a 3-piece IOL on the anterior capsule. It will do almost the same thing what your mesh is doing, and I think that is little more posteriorly placed compared to your mesh which is on the iris. So we are actually working much more closer to the endothelium rather than IOL on the anterior capsule. So the distance between the endothelium to your phaco tip is much less and than the other one.
Even
so what
with
do
the
you think?
IOL scaffold, the pieces are over the iris and
That's
they're
right.
close to the endothelium.
Right,
The
right.
problem with the IOL scaffold is that once you put the IOL under the fragments, then doing a proper vitrectomy and cortical cleanup is difficult.
That's
So
true.
a normal surgeon will have to, it is difficult for them to do it through the anterior route. It's better to do it through pars plana vitrectomy, which not everybody is able to
But
do.
I was seeing that your
Also when you are eating up the fragments over the IOL, you will have to use a dialer and keep shifting the lens so that it covers the pupil, because the size of the optic is much smaller. It is not adequate to cover the whole pupil. So we will always be.
Do you think pupil also helps constricting? You have to bring all the all the cataract pieces in front. Can you constrict the pupil and bring about the similar effect? It can. Anyway, we end the topic there. We don't discuss further. Thank you, Dr. Sheetal. We don't take further time, please. Thank you so much. Yes. Next is Dr. Bindia. At 5.